Good afternoon to you all. I am Dr. Achini Wijesinghe, consultant endocrinologist at Provincial General Hospital, Badulla. I warmly welcome you all to another session of Meet the Experts in Endocrinology, organized by Sri Lanka College of Endocrinologists. I would like to introduce my co-speakers, who are endocrinologists of highest level in the country, both knowledge-wise, as well as living in the high up in the Central Hills, altitude-wise as well. It's my pleasure to introduce Dr. Charles Antonypillai, consultant endocrinologist at National Hospital of Kandy, and Dr. Sonali Gunathilake, consultant endocrinologist at District General Hospital, Nuwara, Eliya. Today, we will be discussing about pituitary apoplexy. Pituitary apoplexy is an acute condition caused by sudden hemorrhage or infarction of the pituitary gland. And the clinical condition of the disease may deteriorate dramatically with significant mortality and morbidity and causing neuroophthalmic sequelae. Therefore, it's crucial to diagnose pituitary apoplexy early and manage appropriately. So I think this is a very important topic to discuss today. So I would like to ask from Sonali. Sonali, what is this pituitary apoplexy? Would you like to elaborate more? And how does it occur? And why does it occur?
Well, thank you very much. And first of all, thank you for giving me opportunity and welcome you all to the session. Yeah, so pituitary apoplexy is an important topic where all the medical officers should know about. It is a medical emergency. It is an endocrine or a medical emergency. And it is an acute clinical syndrome where it is caused by sudden hemorrhage or infarct of the pituitary gland. So I just talked about the pituitary gland. Although I tell it is a sudden hemorrhage or infarct of the pituitary gland, classically it occurs in the setting of a pituitary tumor or pituitary adenoma. So let me just take you through the basic things about this pituitary apoplexy through some images. Okay, so this is, here's my point. Okay, this is the normal anatomy of pituitary gland and its surroundings. I hope you all can see the image. So this hypophysis is the pituitary gland, which is a pea-sized gland and which is situated in the sella turcica. It's a bony cavity where the pituitary gland is situated. So surrounding the pituitary gland is the well-known cavernous sinus where our carotid artery is situated. You can go through my cursor and in the lateral aspect, there are cranial nerves, 3, 4, and 5 branches of 5 and 6 are located. So this pituitary gland is surrounded by the cavernous sinus as well as it is in close proximity to our carotid artery. Not forgetting in the superior most aspect, there is our optic chiasm where the visual fields begin after this. So there's a decussation of optic nerves and there is this optic chiasm just above the pituitary gland followed by the third ventricle and the brain. So and below the gland is the sphenoid sinuses. So you can imagine the pituitary gland surrounded by the cavernous sinus with its nerves and the vessels, and on the top we have the optic chiasm and below are the sphenoidal sinuses. So in visual, the dramatic, in a drawing like thing, we can just put the same things in this kind of a drawing: pituitary gland, cavernous sinus, and the optic chiasm. So these are important when we talk about pituitary apoplexy. Now, if I say, now I mentioned that pituitary apoplexy or hemorrhage or necrosis, ischemia to the gland occurs especially in the setting of a pituitary tumor. So if we talk about a pituitary tumor, these tumors gradually grow in size, and when it is a large tumor, then it can compress the pituitary stalk where the blood supply to the pituitary happens through the pituitary stalk. that can compress the blood supply and causing some relative ischemia to the tumor. Same way, when the tumor grows in size, that might not get enough blood supply to the growing tumor cells. So that again induces some kind of ischemia, which will result in a pituitary apoplexy. Same way, so this dramatically explains now the tumor growth is high and the vasculature is less compared to the tumor cells, causing necrosis or ischemia. Same way, tumors are well known to have a lot of vasculature, and these vessels are not very kind of well-organized vessels. They are very fragile and less organized. So these blood vessels can bleed into the tumor and cause hemorrhages. So we talked about ischemia as well as hemorrhages into these tumors. So what happens if there is hemorrhage? If a hemorrhage occurs to the towards the meninges, which are surrounding these brain structures, that can cause meningeal irritation, and the patient will have headaches and irritation and problems in the consciousness. And also, this bleeding may extend into the subarachnoid space even, causing symptoms. And this bleed can go into the cavernous sinus and cause some thrombosis and increasing in pressure of the cavernous sinus. And same way, this bleed into this tumor can extend and irritate the carotid arteries in our cavernous sinus. What happens if that happens? Then the carotid arteries can go into spasms and cause relative ischemia to the brain, parts of the brain. So that can lead to some neurological consequences. So I talked about the necroischemia and hemorrhages, which occur in pituitary apoplexy. And also, if the bleed goes beyond the pituitary gland, causing meningeal irritation, as well as pressure effects to the surrounding structures, as well as the carotid artery spasm. Same way, the bleed itself can cause problems in the pituitary gland as well. When there's a bleed into the pituitary gland and the tumor expands rapidly and suddenly, right? So this diagram illustrates that. Now, if the tumor expands rapidly, but towards in its longitudinal way, that can compress the optic chiasm, which is just above the pituitary gland and the tumor. So when the optic chiasm is compressed or damaged, then the patient will get some kind of visual issues. I think we will discuss that in the discussion further, but this is how it happens if it compresses the optic chiasm. Same way, if the tumor with its bleed and some kind of inflammation secondary to bleed, it can expand laterally also. Now we know that laterally we have our cavernous sinus and the carotid artery as well as the nerves. So when this happens, again, the pressure builds up within the sella turcica as well as the cavernous sinus, and then compression can occur to the carotid arteries and the nerves. So our optic, the third, fourth, and sixth nerves can get compressed. So we can see some ophthalmoplegia in these kind of tumors. So you may appreciate that the tumors, there's no definite way of tumor enlargement. It may in the longitudinal way, it may do so laterally. So depending on what happens during this infarct or bleed, how the pituitary or the tumor behaves, the clinical features may differ. One last point about how this apoplexy comes about and then what happens. Now, we talked about tumor expansion and the pressure effects. Same way, when there's a bleed into the pituitary gland and the tumor, that will destroy the pituitary functions. So there will be some defects in the pituitary hormonal secretion. So that can also result in clinical manifestations short-term as well as long-term. So this is how the pituitary apoplexy comes about, and how we see the pituitary, the clinical features related to pituitary apoplexy, and this is what is behind the screen or behind the head or sella turcica, and the basic pathophysiology. Now, why do we talk? Why do we have our first this kind of discussion on pituitary apoplexy? Because it's not, although we don't see it very commonly, it is not as rare as some other diseases. So it's like, if we take, we don't have our Sri Lankan data, but if we take worldwide, the prevalence is roughly about 6.2 cases per 100,000. And then incidence is 0.17 per 100,000 person years. And about 2 to 12% of patients with pituitary adenomas do present with pituitary apoplexy. So that is an important number. Roughly about 10% of pituitary adenomas may get a pituitary apoplexy during their course of the disease, or even as the first presentation. And if we take all these patients with pituitary apoplexy, we have seen that commonly it occurs in the 5th and 6th decade, and there's more male predominance than the females. So that's the usual pattern that we have seen over the years. And do all patients with pituitary tumors get this apoplexy? Well, not everybody. Commonly, patients who are having larger tumors of the pituitary, that is pituitary macroadenomas, do get this. And higher the growth rate of the pituitary tumor, more likelihood of getting pituitary adenomas. What the data show is, if the growth is more than 3.5 millimeters per year, there's more chance of a person getting a pituitary apoplexy, either hemorrhage or infarct, due to the reasons I told. And commonly, the non-functional pituitary adenomas have shown to be getting pituitary apoplexy. We are not sure whether because the non-functional adenomas are more common than other functional adenomas in the pituitary. Because of that reason, we are seeing more common apoplexies in those. We are not quite sure. But secondly, if we take the secretory adenomas, commonly the prolactinomas have shown more of pituitary apoplexy than other secretory tumors. And okay, so they are the characteristics of the tumor-wise in those who get pituitary apoplexy. And if we take the precipitants, which conditions cause a patient to get more prone for apoplexy, well, they are not very defined or definite causes. Only about 20 to 40% of precipitants have been identified, and others we don't know what the cause for this apoplexy is. So they have found that increase in intracranial pressures as well as high blood pressure, systemic blood pressures have caused some, have more relationship for developing pituitary apoplexy. One may argue that, okay, pituitary gland gets its blood supply from the hypothalamo pituitary portal system. Yeah, that is the normal pituitary. But if there is a tumor of the pituitary, they have shown that the blood supply of the tumor is more dependent on the systemic circulation, especially inferior hypophyseal arteries, than the hypothalamo pituitary portal system. So that kind of a systemic blood supply to the pituitary tumor can get more reflection of systemic blood pressure than the pituitary portal system. And also, if the patient has undergone procedures like intracranial procedures, neurological procedures, and even dynamic endocrine functional testing, they are also prone for these apoplectic conditions. And patients undergoing major surgeries, even bypass surgeries, the blood pressure fluctuations during the surgeries make them more prone for pituitary apoplexy. And also, if the patient is on antiplatelets and also some drugs, anti-tumor drugs like cabergoline and estrogen and radiotherapy has also shown to have some links with pituitary apoplexy. And recently, of course, we have seen that COVID infection as well as COVID vaccination had some links, but they are not proven. But there are some reports as well as series linking these tumors, the tumor apoplexies with the COVID and COVID vaccination. So basically, that is how the pituitary apoplexy develops, as well as the group of people who are prone to develop pituitary apoplexy. I guess I answered your question, Achini.
Yes, thank you very much, Sonali, for that nice elaboration and illustration how pituitary apoplexy occurs. I think now better to go through a small case history. So we here have a 63-year-old male, non-patient with diabetes and hypertension, which had been well controlled before, admitted with acute severe headache. And he also had vomiting, slight confusion. On examination, his GCS was 15. There was no neck stiffness. There was no other gross neurological abnormality. But cardiovascular-wise, there's tachycardia with pulse rate 100. Blood pressure slightly on low side, 100/70. Blood sugar 200. So, Dr. Charles, can this be pituitary apoplexy or can this be something else? So, would you please elaborate, when do you suspect pituitary apoplexy?
Well, sorry, can you all hear me?
Yes.
Yeah. Right. So thanks, Achini. And I think Sonali has made my life much easier by giving that very clear illustration as to how apoplexy develops. So how I see that is as a storm in a teacup. So if this is a teacup, this is the pituitary gland like this. So this is the sella turcica is this teacup, and then you get the diaphragma cilia on top of this. So then this is where in this context only you get this hemorrhage and ischemia, and where you develop this pituitary apoplexy. So when I say storm in a teacup, we look at the literal meaning of the phrase rather than the idiom, because the idiom means that it's not severe, but it's a very important condition. So let me get back to my point. So here, if you look at this particular case, he presented with sudden onset severe headache. So that is one of the hallmarks of pituitary apoplexy. So if you look at a patient who presents with sudden onset severe headache, usually there are other differential diagnoses like intracerebral hemorrhage, subarachnoid hemorrhage, venous sinus thrombosis, and then there may be other causes like increased intracranial pressure. So one of the differential diagnoses is pituitary apoplexy, which you should not miss. And the other important thing is, if someone comes with a story of a pituitary tumor, someone who already has a pituitary tumor comes with headache, anybody is immediately going to think about pituitary apoplexy. But majority of the time, apoplexy may be the first presentation of pituitary tumor. So therefore, they may not have any clinical features suggestive of a pituitary tumor when they come with sudden onset severe headache. So the bottom line that I want to highlight here is, if someone presents to you with sudden onset severe headache, one of the differential diagnoses, although relatively rare compared to intracerebral hemorrhage and subarachnoid hemorrhage, you have to think about pituitary apoplexy. The other things, as Sonali pointed out, depending on how this hemorrhage, the edema, and the necrosis extends, there may be other signs which may be associated with this. So if they come with like pressure on the superior aspect of the pituitary gland, there may be visual field impairment, there may be blindness. So if you see patients with similar features, always there should be a very high degree of suspicion regarding pituitary apoplexy. And then laterally, there will be ocular palsies. So any neuroophthalmic sign in a patient with sudden onset severe headache sort of makes the suspicion of pituitary apoplexy high on the cards. But other than that, there may be other neurological signs which you should not miss which probably doesn't make you exclude pituitary apoplexy. Now, sometimes these patients can come with meningeal irritation as well, because if this blood extravasates into the subarachnoid hemorrhage, subarachnoid space, it may be similar to a subarachnoid hemorrhage. So there could be meningeal neck stiffness, there could be nausea, vomiting, photophobia. So just because someone has these things, it doesn't exclude pituitary apoplexy as well. And very rarely, as Sonali said, there could be compression of the internal carotid arteries, and there could be vasospasms. So these also can give rise to focal neurological signs. So still, they can be associated with pituitary apoplexy. And as endocrinologists, the other important thing that we should highlight is the most important and life-threatening thing is, in addition to the neurological things, the pituitary gland itself can be compressed, and they can get acute hypopituitarism. And cortisol deficiency is a very common thing in this. In about 70% of these patients can come with cortisol deficiency. So therefore, there should be a high degree of suspicion, because that can be life-saving, because cortisol deficiency can be life-threatening in these patients. So if someone has hemodynamic instability, hyponatremia, confusion, always think of cortisol deficiency in this patient, where you may have to start on steroids. So we will discuss that later. And another important thing is, here we said that most of the patients with pituitary tumors, when they present with apoplexy, we won't have any evidence to say that they had a pituitary tumor. But still, quite a number of them, retrospectively, when you take the history, they might have features of hypogonadism or thyrotroph deficiency. So when you look at these patients, you can probably take a history, and then quite a number of them might, although they had not presented to a doctor with hypopituitarism related symptoms or signs, still when you question them, they will be telling these things. So these are the important clinical features of pituitary apoplexy. So based on this, what I would suggest is, now coming back to Achini's question, in a nutshell, if somebody presents with sudden onset severe headache, always think of pituitary apoplexy, especially if there are associated neuroophthalmic signs. But the other important thing is, look for hemodynamic instability and features of hypocortisolism long before you get your rest of the investigations, because sometimes steroids may be life-saving in these patients. And the third thing that I would like to tell you is, just because there is signs of meningeal irritation, focal neurological signs, that does not mean this person does not have pituitary apoplexy. So I wonder whether that gives the answer to Achini's question.
Yes, thank you very much.
So then I think it's my turn to ask a question from Achini. So if you suspect pituitary apoplexy, or in this kind of a scenario, how would you proceed with the rest of the investigations?
Yes, anybody presenting with acute severe headache and some neurological signs, I think the first line investigation anybody would like would be the non-contrast CT brain. Especially, we need to exclude any sort of intracerebral hemorrhage or subarachnoid hemorrhage in a patient with acute severe headache. So if we look at a non-contrast CT, and if we are lucky enough to get through a pituitary cart, you would be able to see hyperdensity within the region of the pituitary. In this image, if you look at the pituitary fossa, you are able to see a soft tissue enhancement as well as a hyperdensity within the gland. Hyperdensity in a non-contrast CT is mainly due to blood. So once you look at the CT, all the films, if there is no any other intracerebral hemorrhage or subarachnoid hemorrhage, you have to strongly suspect pituitary bleeding into the pituitary in a non-contrast CT. Then the gold standard to diagnose pituitary apoplexy would be MRI. If you look at MRI in a T1 weighted image, first, MRI would show two things. One thing is you would be able to characterize the tumor. as well as you'd be able to demonstrate blood within the gland. So if you look at the first image, which is the sagittal image, you would appreciate the pituitary gland is enlarged. So that is, there is a tumor and it is extending superiorly, and it is a causing compression of the optic chiasm. And also there is some lateral extension. You would be able to see the internal carotid arteries on the either side of the glands in the sagittal section, as well as on the coronal section, in the coronal section. And if you look carefully, you would be able to see hyperintensity within the gland. Hyperintensity in MRI imaging is mainly due to bleeding. So in this, this is actual images of that patient. So he has bleeding into the pituitary gland. Apoplexy could be due to hemorrhage, or either could be due to necrosis. If that is necrosis, if mainly the fluid is there in the T1 weighted imaging, mainly it will be hypo-intense. Hypo-intense means it is more blackish. Hyper-intense means it is more whitish. So if there is necrosis, it will be more hypo-intense. Sometimes you would be able to see a combination of both hemorrhage and necrosis. Sometimes in some patients, you would be, if there is a necrosis has been there for some time, you would be able to see the fluid level within the gland occasionally. And if you look at the T2 weighted image, it is more or less the opposite. So bleeding will be hypo-intense, that will be more blackish in T2 weighted MRI imaging. So if you see the pituitary gland, it is completely opposite. You will see you can see the tumor in the coronal, and it is more hypo-intense, more blackish. And if there is any necrosis, that would be hyper-intense, but it is not, which we'll hear, I think, in this lesion. Otherwise, if there is necrosis, it will be hyper-intense in the T2 weighted imaging. So, so now we confirm the diagnosis in this patient. The patient is having a large pituitary adenoma, on slide with slight compression of the chiasma with bleeding into the gland. So when this patient come to you, Sonali, what would you do?
Okay, so we have a patient who has a pituitary tumor and clinical evidence of pituitary apoplexy, highly suspicious, and also imaging evidence of possible pituitary apoplexy. So like Dr. Charles said, this is a life-threatening condition. So the most life-threatening event immediately we have to think is there a hormonal imbalance? As I remember in this patient, his blood pressure is somewhere around 100/70 and he is a little bit tachycardic. So I would consider this as an emergency, medical emergency, and he's hemodynamically not the optimum for that aged patient, and tachycardic, slightly lowish blood pressure. So my first emphasis goes into stabilizing this patient. So airway, breathing, circulation, normal basics of medical emergency will apply here. And then immediately taking bloods for basic bloods like electrolytes, full count, clotting profile, renal functions. I'll arrange them. And same time, if possible, without spending time, if they are taking bloods by putting a cannula, then I would take a blood sample for random cortisol, TSH, T4 at least, not to analyze then and there, like, you keep it, and then I will proceed with my immediate management. So the thing, like having the thought of pituitary apoplexy in the back of my mind, the next immediate thing is this patient is having marginally low blood pressure and also a little bit of confusion. So is there any possibility of cortisol deficiency is the first thing that I would think. Because if the patient has cortisol deficiency, if we do not treat, that will cause the deterioration of the patient. If we treat it, then yes, that will resolve the immediate acute issues of cortisol deficiency. So my first thing after initial stabilization, hemodynamic, the very next immediate thing is to give steroids, because this patient is having some features of hemodynamic instability. So I will start him on IV hydrocortisone, that is the preferred steroid. Like there are different regimes that we practice. So I would either give 50 milligrams IV hydrocortisone 6 hourly, or we can give a bolus and start maybe 100 to 200 milligrams IV hydrocortisone stat IV and followed by 50 milligrams 6 hourly. And one might even consider giving an infusion of roughly about 2 to 4 milligrams per hour IV hydrocortisone infusion. Whatever it is fine as long as we promptly start him on IV hydrocortisone. And yeah, so while doing that, I will make sure the patient is well fluid resuscitated and electrolytes are well within range, and his blood glucose is also optimized while the hydrocortisone kicks on in the system. So that is the main immediate action. And one might ask, there may be a question, okay, do we give hydrocortisone to all the patients? Well, classically, what is recommended is you start on hydrocortisone on clinical suspicion. You do not wait until the cortisol report is available. If the patient is showing any features of hemodynamic instability, or if the patient is having low GCS, or if the patient is having some kind of a visual problems in the visual acuity or visual fields. If you detect that, if the patient tells that, okay, can't see the sides, you don't do a proper test, but still there's no harm in giving IV hydrocortisone if the patient has those features: hemodynamic instability, low GCS, visual acuity or visual field problems. So those are the classic features. But if you suspect any features of pituitary apoplexy, and if you have the slightest doubt of cortisol deficiency, there is no harm in giving hydrocortisone. That point I need to stress to you. And the next question some may ask is, why not dexamethasone? Can we give dexamethasone? Well, the guidelines do recommend hydrocortisone because hydrocortisone is the kind of the best replacement for cortisol deficiency. Well, in certain centers, some may use IV dexamethasone, roughly about 4 milligrams 12 hourly, or there may be different regimes to replace cortisol deficiency, as well as some surgeons do prefer to give dexamethasone with its anti-inflammatory properties to reduce the surrounding swelling of and associated swelling of a pituitary adenoma during its acute bleed. But principally, we use hydrocortisone to replace the cortisol deficiency. So I've managed the initial hemodynamic part, and I've managed the possible cortisol deficiency. And then with careful monitoring, then if possible, the patient is in good sound mind, I can do a bedside visual field assessment until the tests are arranged. And it's mainly a multidisciplinary team management. Then immediately the multidisciplinary team referrals should be made in the acute setting itself to the neuro-ophthalmology, neurosurgery, and also endocrine team to look into this patient and take the appropriate immediate next steps. So this is my acute management of this patient with pituitary apoplexy in the ETU or PCU setting, or in the ward setting acutely. And well, the next step is the next immediate management. So after the acute management, I think probably Dr. Charles would be able to enlighten us or give us more insight on what the next step is. What are we going to do now? Now I have managed this patient acutely, and now the patient is safe. Patient is not collapsing hemodynamically. Okay, so how are you going to manage hereafter? You are going to take over this patient for the next shift. Immediately, I'm off now. So what are you going to do? What are you going to plan if you are the doctor who's taking over the patient now?
Thank you, Sonali. So you have done the most important thing of making this patient live for me to take over, because the most important thing, as you said, is resuscitating the patient. giving hydrocortisone is not going to kill the patient, but if you don't give hydrocortisone, very likely the patient will die if he's having cortisol insufficiency. So now my task is a little easier, but in the meantime, it is very controversial, as it's not as clear cut as what you had to do in that particular context. So the two options that we have are, it's like the William Shakespeare question, to be or not to be, that is the question. So here what we ask is to cut or not to cut, that is the question. So to answer that question in a world where we live and practice evidence-based medicine, this is a data-free zone where we don't have enough data to see which is better, whether it is surgery or conservative management. When we don't have randomized controlled trials because of the relative rarity of this condition, we have to go by retrospective studies. So the retrospective studies are also not very strong in terms of evidence because there is a very high selection bias. So when you take a person to the theater, that person obviously is going to be quite severely ill with more complications of the condition. Whereas when you manage someone, decide to conservatively manage a person, they are very likely that person is going to have a milder form of the disease. So when there is a selection bias, you are not comparing two equal groups to really come up with very strong evidence. So therefore, here what we have to go by is some of the other like parameters and advantages of disadvantages of each option. So if you look at surgery, early decompression will probably minimize the damage to the optic chiasm especially, as well as the surrounding structures. And in the meantime, by doing surgery, because most of the time we are talking about pituitary apoplexy in the context of a pituitary lesion. So then in one go, you can probably treat the pituitary tumor as well. But the downside of surgeries, it can end up with CSF leak, and then there could be hypopituitarism, and then permanent diabetes insipidus. So these are also fairly significant morbidities which you have to take into account. And when you do urgent surgery, sometimes you may not be able to access the best surgeon. So as a result, the complications also could be more when you go for surgery. But on the other hand, if you think of conservative management, there it will take time to improve the pressure effects on certain structures. But a study done in Oxford, what they have shown is if you try to decompress the effects on the optic chiasm, the pressure on the optic chiasm within 8 days, then there is good recovery. But on the other hand, if there is a delay, then there could be permanent blindness or visual field defect in that patient. So then again, what it says is conservative management, although it's good in terms of visual field recovery, sometimes you may not be doing enough. But on the other hand, the interesting thing is if there is cavernous sinus involvement and ocular palsies, there they have shown that even with conservative management, after days to weeks, the ocular muscles, they improve. So probably the damage to the nerve is not permanent, unlike what you might expect in the optic chiasm or the optic nerves. So therefore, the question is, there are two options, but which one would you choose? So if so there is this UK pituitary guideline which was published in 2011, and then in 2015 also again there are certain consensus statements. So there what they say is, if there is reduced level of consciousness or severe neuroophthalmic signs. So when you say severe, even that is not defined properly, but if the person has significant visual field defects or something like that, then you have to consider surgery. But having said that, it has to be done by a multidisciplinary team. So here the endocrinologist, the neurosurgeon, and if the facilities are available, a neuro-ophthalmologist should be part of this particular team in decision making. So, but the important thing is cranial nerve palsy per se is not an indication for surgery. But if there is significant visual field defect, you have to go for surgery. So at this time, I would like to elaborate a case which we came across a couple of weeks back. So this was a young boy with a macroprolactinoma, and he was on cabergoline. And then about 2 weeks back, he presented with sudden onset headache to Sonali. And then Sonali brilliantly made this diagnosis of pituitary apoplexy. And while monitoring to see within days, his visual field was deteriorating. And I think Sonali showed me the visual fields as well. So all of a sudden, he went into bitemporal hemianopia and the headache persisted. So finally, with this,
I've shared the visual fields for your reference.
yes, brilliant. Yes. So then the patient was sent for surgery, and within 7 days, we managed to do the surgery. And luckily, his vision is not only the visual field, even the visual acuity deteriorated there. He's a child doing his A-levels. So therefore, studies is very important. He's a badminton player as well. So then luckily with surgery, we have managed to reverse most of the neuroophthalmic signs, and he is doing quite well now. But on the other hand, the previous patient whom Achini showed, so again, it was a relative of one of the doctors working at our clinic. So initially, he had this mild confusion, but with steroids and all, he recovered. So when we did the visual fields, there was nothing major there. So there we decided to manage him conservatively. So, but when you manage a person conservatively, the most important thing is you don't know which course the bleeding will take. Sometimes the person can deteriorate, sometimes the person can improve. So then it can go either way. So therefore, you must be more careful, and very close monitoring is very important. So initially hourly monitoring, and after that, so he has to be in probably a neurosurgical ward. And then if things are fairly all right, then you can reduce the frequency of monitoring. Otherwise, if you just say the decision is to manage conservatively, and after that, if you don't question your decision, again, the patient might deteriorate and you will lose out on so many things in that particular patient. So carefully monitor. And then if the patient is stable, you will probably continue to monitor him. And then it comes to the question of long-term treatment. So have I answered the question?
Yes. I think that's
Sonali?
yes. Thank you, Dr. Charles, regarding when and how to do medical management and when and how to do surgical management. Yeah. I think next would be, now, since you talked about the acute one, then the immediate ones, then you pointed out the long-term management as well. Yeah. So probably shall we ask Achini to elaborate on the long-term management?
All right. Now we have managed the acute part. Then we have to look at the long-term management. In long-term management, we are looking at mainly two things. One thing is the pituitary hormone levels, that whether there is deficiency and whether the axis is recovering. On the other hand, we have to look at the tumor progression. First, look at how do you monitor the pituitary functions. Initially, now we know this patient is cortisol deficient and patient is on now hydrocortisone. So you should keep patient on hydrocortisone, and then you should be monitoring first in about 3 months time, and then at least annually you should recheck the pituitary axis whether the patient is recovering. If the patient is recovering, you can slowly come off the hydrocortisone. And now also we have to check the other pituitary hormone levels, especially thyroid functions. You have to check TSH and free T4 in the acute setup. And if they are low, you have to start on thyroxine replacement with the hydrocortisone. But even if the TSH and T4 are normal, you have to retest in about 2-3 weeks time, because sometimes hypopituitarism, secondary hypothyroidism may be delayed. So just retest your thyroid functions in about 2-3 weeks time. And if that is normal, it's unlikely that patient will develop again, but you can monitor annually. Then again, you have to check your LH and FSH for your gonadotropin function. And if they are impaired, you can wait and see whether if it's a female, whether the patient will develop menstruation for a few months. And if not, then you have to start on hormone replacement, estrogen in females and testosterone in males. And again, you have to retest periodically for the recovery of axis. Another important thing we might forget is prolactin. What is the importance of prolactin in pituitary apoplexy? Usually, in pituitary apoplexy, if your prolactin levels are very low at the onset of pituitary apoplexy, that may predict that you are going to be long-term hypopituitary, because that is an indirect measurement of the intrapituitary pressure. And if your prolactin is very low with the acute apoplexy, and most likely you will not recover, your gland will not recover after the years to come. And another thing is that if your prolactin is normal, that can happen in a prolactinoma as well. So it's very important that you check the prolactin levels in few months' time, about 2 months and 6 months' time, to make sure you are not missing a prolactinoma where you could have easily managed with cabergoline. So in an apoplexy, it's very important that you periodically check your prolactin levels in the subsequent visits. And then if you look at the tumor progression, if you opt for conservative management pathway, now we have to always keep in mind the tumor is already there in the cellar. So it can regrow, it can stay same, or it can shrink after the necrosis. So the most UK guidelines would recommend repeat imaging in MRIs in about 3 to 6 months time, and then in 1 year, and annually for about 5 years. But in our practice, Sonali and Dr. Charles would also agree with me, we might not have the luxury of repeating MRIs that often. So you have to discuss with your radiologist and neuro-ophthalmologist. You have to consider the size of your tumor, the proximity of the tumor to the optic chiasm, and then you can decide on your own how frequent am I going to repeat this MRI. Even if you opt for the surgical pathway, again, you have to repeat your MRI at least in 6 months to 1 year's time just to make sure you don't have the residual tumor, or whether there is any recurrence of the tumor. So, so the acute part management, and now we have gone through the long-term management. I think now you're much confident in managing pituitary apoplexy than we started the discussion several minutes back. I think we have very important take-home messages. Dr. Charles, would you like to express the take-home messages?
Yeah, well, after listening to your presentation, Achini's presentation, Sonali's presentation, and what I gathered, I think we can summarize this into 3 take-home messages. First thing is, if somebody comes with sudden onset severe headache with or without neuro-ophthalmic signs, we have to think of pituitary apoplexy. So that is something. So if you miss it, then you are never going to consider it as a differential diagnosis, and then the patient might lose his life. The second thing that we have to remember is, like Sonali emphasized, in these patients with pituitary apoplexy, don't deny them steroids, whatever the form. Hydrocortisone is the preferred thing, but don't deny them steroids, because if you forget to give steroids, that might kill the patient. So therefore, it's very important to give steroids in these patients, have a very low threshold to treat them with steroids. And the third important thing is, don't deny surgery in patients who actually need surgery. So patients with pituitary apoplexy, you have to liaise with the neurosurgeon, the endocrinologist, and the ophthalmologist well in advance. And then when you do the surgery, you have to do it within 7 days if you were to get the benefit, reap the benefits. Otherwise, there could be permanent damage to the optic nerves. So therefore, those who really need surgery, well in advance, be in touch with the relevant people, prepare the patient for surgery so that the his vision is especially saved, and it can be life-saving as well. So these are the 3 important take-home messages I would like to give to the audience at the end of this webinar. Over to you, Achini.
I think this brings to an end of our discussion on pituitary apoplexy, and I would like to thank Dr. Charles Antonypillai and Dr. Sonali Gunathilake for the nice discussion, and for everybody for your participation. Thank you very much. Hope you have a great day.
Thank you.